If you are looking into starting your own cardiac CT practice, SCCT has developed a tool to help you efficiently achieve your goal. The SCCT Starter Kit is a broad set of resources compiled by clinicians working in partnership with industry professionals. The kit is a one-stop collection of information that includes financial and operational planning templates, resources for clinical procedures, guides for personnel training and credentialing, device and equipment information, marketing tools, and more. Resources are available by link or for download. Subscribers have access to a Q&A and discussion forum. Check it out at scctstarterkit.org. Hello, everyone, and welcome back to another episode of the Donut of Destiny, the podcast on all things cardiac CT for anyone interested in cardiovascular imaging. My name is Praveen Ranganath, and I'm a radiologist from Dallas, Texas. On today's episode, I am joined by Dr. Frank Corrigan, who is an interventional cardiologist and CT imager practicing in Atlanta, Georgia. Frank, welcome onto the podcast.
Well, thanks for having me, Praveen.
Hey, my pleasure. Thank you again for joining us. Today, we are going to be talking about what it takes to start and grow a cardiac CT program. As we all know, institutions can vary in a tremendous number of ways, which includes size, location, patient demographics, the types of referrents, types of readers, academic versus private, and all sorts of other details. I hope that this episode is going to be the start of a series of episodes on how to start and grow a cardiac CT program based on the experiences from all different types of institutions. But Frank, let's start by talking about you and your practice. How did you get into cardiac imaging? Where are you practicing? And what type of healthcare system are you in?
Well, thanks, Praveen. So I work for Wellstar Health System, which is a 9-hospital system in Georgia. And over the last couple of years, we've really started to invest in cardiac CT, primarily from a structural heart perspective and more recently in an evaluation of chest pain perspective. If we think about the recent chest pain guidelines, the first time we've ever actually had chest pain guidelines from ACC, there's a large emphasis on coronary CT imaging. And our group's really bought into that. So that's where all this has come from. But we're a private system and have multiple hospitals throughout the state. And so it's been a little bit of a challenge trying to bring everybody up to speed as nuclear imaging and stress echo, especially for the evaluation of chest discomfort, has become the mainstay of therapy for 30 years. So to try to change that inertia has been quite a project, but we're making improvements.
Absolutely. So you were kind of alluding to performing a robust needs evaluation before getting any sort of program, including a cardiac CT program, off the ground. Were you practicing at Wellstar prior to the initiation of the program and therefore were part of that needs evaluation? Or was it sort of readily apparent what questions needed to be answered and having cardiac CT as a solution as part of that?
I think the difficulty with cardiac CT for years had been that a lot of our colleagues, and specifically cardiologists, didn't really trust cardiac CT. And I think that was because a lot of times the patients weren't prepared right and there were artifacts. And so a lot of my kind of older colleagues were used to getting these reads where we think there's not a lesion, but we can't rule it out. And they just weren't satisfied with that. So I started at Wellstar 4 years ago. And with a lot of focus on patient preparation and technologist training, we've been able to change that perception. And at this point, as it should be, I think it's a fantastic test for the de novo evaluation of chest discomfort in intermediate to even high risk patients. And that's what our guidelines say at the moment. And it's taken, every health system a little bit of time to get there. But yes, we did have coronary CT imaging before I started, but not to the level that we do now. And it's been about changing perceptions amongst providers, amongst patients, in that they understand they're going to need some medicines at the time of their test, and then amongst our technologists that coronary CT or cardiac CT isn't just a test on a CT where you press a button. It requires a lot of nuance, understanding the cardiac rhythm cycle, et cetera, to really optimize the study.
Absolutely. I think you've touched on some really good points about the general inertia in terms of pickup of cardiac CT as a solution to various problems in cardiovascular medicine. I want to dive a little bit into some specific components now. You mentioned that your group services quite a few hospitals around the Georgia area. Are these community hospitals of a smaller or medium size? And if so, what sort of unique challenges are brought by that type of hospital system relative to, say, a large academic center or a different area of the country?
So our system, we have one kind of large hospital that has pretty much all services, and then the other hospitals are all kind of small community hospitals. In the small community hospital setting, particularly in a cardiology office setting, a lot of our offices have nuclear machines, and the concept of starting to divert business away from those nuclear machines was a difficult proposition. And I think when you're in kind of a smaller hospital, smaller community hospital setting, it it can be a difficult sell because we're changing the paradigm of how we evaluate our patients. And primarily stress testing, particularly nuclear stress testing, has been a revenue source for these practices for years and years and years. And then to say, hey, look, we're going to shift to a different test, which may mean that these dollars go elsewhere, has been a difficult sell for the smaller hospitals. But if you look at the data and look at what's best for the patients, and then you look at the downstream effects of, hey, we're most of the time detecting non-obstructive coronary disease well before we would have otherwise. As the literature says, we are better able to offer revascularization based on coronary CT. And a lot of times we find other things that could be causing the chest discomfort on a CT that we wouldn't find on a stress test. If once you start to look at all that, it's better for the patients. And when you look at a large system as a whole, it's better for the system. And so that's been a challenge. But in the large kind of academic center, I think there's a lot more flexibility that allows that conversation to not be as much of an issue.
Super interesting points. There's actually a lot to unpackage there, Frank. I want to start with what you've alluded to with regards to the typical community practice in either suburban or rural parts of the United States where we have nuclear cameras that are in office. And with the advent of cardiac CT, we're seeing a potential shift to out of office imaging, more in hospital imaging. How did how did your reference swallow that pill? Did it go smoothly, or were there bumps along the road? And if so, how did you try to smooth those bumps out?
Our cardiology group is hospital employed, and we're employed by the system. And that, made it to where this was less of a problem, I think, in that if revenue was lost in the clinic, if it was going to the hospital, it's all part of the same pool. And at the end of the day, we want to just take care of our patients, but money matters. That's how we support our staff. That's how we do the new things we want to do. And in kind of the strict private practice where I'm a private group that contracts with the hospital, I have my nuclear machine. How do you tell someone like that, hey, look, now you need to send your patients to the hospital to get a coronary CT? Yes, it's going to be better for the patients in the long run, but what does that mean for the staff I need to support in my clinic? That is a difficult issue. And on top of that, nuclear stress testing reimburses more than coronary CT. So how do you someone that's looking at the numbers, looking at dollars and cents, it's a tough proposition, and I get that, and something that we dealt with since we were hospital employed. It was more of a shift, and things would work out. But in a true private practice setting, I can see how this would be a difficult proposition. That being said, I know there are a number of small private practices where they're interested in purchasing a cardiac CT, like a cardiograph, which can be a fantastic solution for patients. They're small; they can probably fit where a nuclear machine was, but that's a big undertaking. Requires staff training, et cetera, which can make it tough.
A lot of what we're talking about revolves around resource management, which is it's pretty critical and pretty difficult at times in the community setting. When it comes to things like hardware upgrades, software upgrades, education of our technologists and nursing staff, were there any particular tips or tricks that you had utilized in your practice?
Starting out, just from a provider standpoint, getting away from the financial implications of this, one of the big challenges was getting our providers to buy into heart rate control. A lot of people were used to ordering stress testing or used to ordering, whatever test, and you just put the order in, and in a week or two, the test is done and you see the results. But changing the perception of, hey, look, we're going to send you for a coronary CT, and I'm going to prescribe you metoprolol or whatever medicine for rate control. That was an interesting conversation that required some adjustment on our provider's perspective. A lot of people thought, well, this, whose responsibility is this? Is this the radiologist's responsibility? Is this the cardiologist's responsibility? And we had to change the minds of our providers to say, hey, look, if I want a good study, I want to prepare my patient appropriately. And once we kind of started to convince people of that, and convince people that coronary CT is a procedure, not just a test, things started to come around. And preparing our patients appropriately really has increased our image quality. We've partnered with HeartFlow as well, and they've been very helpful in helping us focus on quality. But that little piece, I think, allowed us to essentially triple coronary CT imaging over the last 3 years. So that's one piece. The next piece is, with the growth of structural heart, cardiac CT is going to be the mainstay of imaging for these patients. We've seen a shift in how we evaluate patients for left atrial appendage occlusion, from a completely TE-based strategy to now nearly a completely cardiac CT-based strategy, both before and after the procedure. And I think that's a whole lot safer for the patient. If you could imagine, some of these patients were getting 3, maybe even 4 transesophageal echoes in a year. And these are very kind of frail patients that are high bleeding risk. And it just kind of didn't really make all that much sense. So now we're able to offer a cardiac CT both before and afterwards, and complete that evaluation, which I think is a win for our patients. Again, the inertia amongst providers and who's doing the testing, where these RVUs, et cetera, end up falling, is something that takes some adjustment. But in my view, if we do what's right for our patients, everything will shake out appropriately in the end. And those are 2 issues. There are many, many more. I could go into technologist training and all that stuff, but
yeah, definitely. I think the buy-in from your local referents, as we were kind of discussing in the early part of our conversation, is sometimes easy, sometimes hard. There may be referents out there that are super familiar with the advantages of CT, and those that may understand the technology of CT but still be resistant. I wonder if we're going to see a combination of both internal marketing for CT as a solution for cardiovascular problems, as well as simple growth of knowledge amongst non-CT practitioners. Regardless of the answer to that question, you had mentioned technologist and nursing education as a component of delivering care for our patients. Was curious as to how you approached educating your technologists or capturing well-educated technologists that are already out there for your practice?
So what we did is cardiac CT requires a lot of knowledge about the cardiac rhythm cycle. That's how you optimize the test. So if your technologists aren't familiar with that, it's not going to make for a good study. So in our system, we made a few cardiac CT technologist kind of champion positions, which were carried increased salary, and people had to demonstrate that they had a certain amount of training. We have one kind of lead technologist for the system that supervises that training and kind of checks people off. But you've got to incentivize your staff, and that's basically what we did, because that's how you get a good study. On top of that, before I started, coronary CT imaging was not utilized as much in our system for some of the reasons I've mentioned, that many of the studies were suboptimal and had artifact. And so because of that, we were doing coronary CT at many sites, but very low volume. And, one of the first things I did is said, hey, look, let's, consolidate coronary and cardiac CT to a few locations just to allow our technologists to get some rhythm and understanding, the nuances of cardiac CT. If you try to do cardiac CT on a machine that's doing, 30 scans a day and one happens to be a cardiac, and that's not a recipe for success. So we've started to spread out coronary CT now, but initially we had to consolidate things and then come up with a plan as to how we're going to incentivize our technologists to get trained and also be excited about coronary CT. On top of that, we're given nitro and beta blockers at the time of these procedures, so you really need nursing involvement to really optimize our studies. And a lot of these patients have been patients that were coming for CTs thinking, hey, look, I'm just going to get a test and in and out. But, we had to convince people of, hey, look, we're going to give vasoactive medicine, so they're going to need a little observation afterwards. Most of the time, it's just observation, that's it. But occasionally people need, 250, 500 milliliters of normal saline afterwards, which, that's a whole logistical thing that can make it difficult. But if we do all those things, we can have, a fantastic test that tells us so much more than any other test about the heart. And I think as we move forward, coronary CT is going to eventually become kind of a screening test, because we can see the non-calcified plaque, which is what we've always been interested in. For years, if you go back to the Courage trial, et cetera, these kind of non-obstructive, non-calcified plaque is what causes heart attacks, what causes problems. And if we can intervene upon that sooner, primarily with preventive medicines, we're going to change the way we practice cardiology. And, that's my hope down the line, but a lot of steps to get there.
I could not agree with you more. And I think that the strategies you've outlined, particularly with regards to those of creating a technologist and nursing champion and initially consolidating efforts at one site to have your special site where everyone can learn and then grow from there, super helpful and clearly bearing great fruit on your end. And with regards to your points on where we see the field of cardiovascular medicine and CT marrying one another is in exactly what you've described, that characterization, quantification of atherosclerotic plaque burden. More and more, we're seeing that, yes, stenoses are important, but there is so much more to coronary pathobiology that we're able to gather from this fantastic test if it's done right. I want to shift gears just a little bit and ask about the types of CT readers that are in your program. Are they entirely cardiologists? Are they a mixture of cardiologists and radiologists? And if they are cardiologists, what component, if any, involves your radiology colleagues?
So that's a very important question. We have a large private radiology group named Quantum that we work closely with. They have a number of cardiac readers, and at present, I'm the sole cardiology reader. but we're in the process of hiring more cardiologists, and we want to make this, a collaboration both between radiology and cardiology. So for the most part, we're kind of a radiology based system, but in order to do cardiac CT, you need to have good buy-in from the cardiologist because you've got to optimize these studies, and that's where the patients are coming from. So this has been an ongoing collaboration for the last 3 years, and in doing all that, we've been able to really improve our studies and make everybody excited about coronary CT and excited about the findings we get. So specifically, when a cardiologist reads a cardiac CT, we're responsible for the heart, and the other findings are a separate report of non-cardiac findings that the radiologist dictates. And I think that's kind of that's kind of the usual model. We have a special contract rate, et cetera. But is that how this flows in your system, Praveen?
Yeah, it's a combination of that in addition to several sites where it's either entirely our cardiology colleagues that will do the reporting or entirely our radiology colleagues. So it's the most common being exactly the model you've described and you're practicing in your system, where we work together in collaboration to report the cardiac and non-cardiac findings. But there are sites that we service where there are only radiology readers, and therefore only radiologists interpret the entirety of imaging. And there are several, much fewer though, sites where our cardiology colleagues will report the entirety of exam without any additional non-cardiology or non-cardiac overread. There's pros and cons to each method. I don't think there's necessarily one that's right or wrong, but ultimately it's what we think is going to do best for our patient population.
I think it's interesting that you have cardiologists doing the entirety of the report at selected sites. There's been a lot of concern about liability in that regard, but whatever works. I mean, there's not. This is a evolving collaboration and transition, and we're trying to do what's right for our patients.
Absolutely. In building any practice, kind of as we're alluding to, there's always going to be something unforeseen that causes a problem along the way. Are there any specific examples of things in the growth of your cardiac CT program that you did not anticipate that caused a bit of a headache?
When we first started with heart flow, this was about 2 years ago, trying to understand what incremental value that brought to the study was a bit of a challenge initially. Specifically, I think the FFRCT analysis is, as an interventional cardiologist, it's something that I'm incredibly familiar with. I do invasive FFR all the time, and to then see that on a coronary CT was something I was, this made a whole lot of sense to me. In trying to translate that to a general cardiologist or a radiologist, it was a little bit more difficult of a concept. And so specifically, and this is not unique to our system, patients that have a low FFR value distally in the LED, which is when it was like a slow taper, we in the cath lab would know that that's not something that's going to benefit from a PCI or a limited LED. Initially, there was a lot of alarm from something like that, and we had patients show up in the ER saying, "Hey, I got this new test, and everybody's worried about me, but I kind of feel okay. What's going on?" So trying to update people on what FFR is and how that adds to the testing and how that is a better strategy for evaluating the intermediate lesions was a challenge initially, but we over a couple months that slowly started to change and people started to understand it a whole lot better. And now I think it's, a fantastic addition to our studies. I was a little surprised by the resistance amongst some of my colleagues in prescribing beta blockers prior to these tests. That's been something that has been an ongoing issue, but I think we've overcome that. We use the Epic system, which I think is the most common EMR in the country. And essentially, I just attached a metoprolol order to our coronary CT order, such that you had to click it off if you weren't going to provide that. And, that required some education, but people bought into it, and it's really helped the studies. So, I had to kind of put it in everybody's face to get them to do it, but it was necessary. And, I think everybody agrees it was the right thing to do.
So, to clarify on that, Frank, with regards to the point about medications prior to procedure, was there resistance to adding additional orders to the coronary CT order, which it sounds like you eventually bundled into an order set? Or was it simply giving a powerful vasoactive medication at the time of an exam, which would not have otherwise been done for other routine CT?
People were worried about giving a powerful vasoactive medicine to these patients. And so think about it in the converse. If we're going to do a exercise nuclear stress test, we hold the beta blockers if they're on one, or whatever agent that might be slowing the heart rate, and then we're going to give them a radio tracer. And I just convince people, hey, look, we're that's what we're doing during that test. Why can't we do something a little differently for this test? And then on top of that, if you don't do it right, these patients are going to end up in the cath lab and then be subjugated to much more risk. So let's optimize the studies, and let's do everything we can to get it right on the front end. And that's a conversation that took a little bit, but I think I've got everybody bought into it now. So it was more just, hey, I want to order a test. I just don't want to prescribe someone a vasoactive agent when I think they may not need it. And that conversation saying, hey, look, this is really how we optimize the study. And on top of that, I do believe it needs to be the referring provider who knows the patient prescribing these medicines. I've heard from people that say, well, if the radiologist is going to supervise the study, why aren't they ordering these oral beta blockers? And I get the discomfort in that. If you haven't seen the patient and you're not used to prescribing these medicines, I mean, why should it be your responsibility? So again, this gets into just the collaboration that's required to really get the program off the ground and get good quality studies. Because if you're not getting good quality studies, you're not going to get anywhere. And then that's where we were 4 years ago. But with technologist training, convincing people that coronary CT is a procedure that involves beta blockers, ivabradine, both oral and IV, sublingual nitroglycerin, et cetera. Convincing people of that allowed us to make improvements. And it's a process, and I think it's a process everywhere in the country.
Well, Frank, you've clearly built a thriving program now, and I'm curious about where you think the future of your program is, or what you're most excited to see come into your program.
What I'm excited about is really growing coronary CT as kind of a longitudinal assessment for some of our patients. And I know that this gets a little bit out of what the current scope of coronary CT is, but what I see down the line is we're going to have a patient that's middle-aged that has risk factors, and a calcium score is a decent test, but again, it doesn't really show us. It's a surrogate for the non-calcified plaque. In other words, if someone has calcium, they must have non-calcified plaque, and that concept to a patient is a very difficult thing to explain. But what I'd like to see down the line is that coronary CTA becomes, in some ways, a screening test for non-calcified plaque. And then in doing that, we can then start statins or even some of the more powerful injectable medicines, Leqvio, PCSK9 inhibitors, to really modify that plaque and reduce their risk. And then, we have patients come back 3-4 years later and then repeat the test to kind of see what we've done. To order a coronary CT to do that, I think would raise a lot of alarms with an insurance company present. But I think that's where we're going to get down the line. And that is, something that as a cardiologist, we've wanted to do for years. You think about treating a patient and preventing problems, to be able to show a patient, hey, look, this is in your heart artery, this is the plaque, and this is why I'm giving you these medicines, is a much just, for one, easier sell to start a patient on a statin, but two, it really allows you to show a patient what you're doing for them. So I'm particularly excited about that. From a structural heart perspective, we can pretty much plan and almost simulate the execution of procedures based on what we see on the cardiac CT, whether it's TAVR, whether it's many of our mitral procedures, whether it's going to be tricuspid procedures down the line, and even left atrial appendage closure and some of the more nuanced procedures. From a procedural planning standpoint, we can make these procedures so much safer with a good cardiac CT beforehand and really simulating these procedures before we get to the lab. And in that regard, I think we're going to eventually start to plan our coronary interventions based on our coronary CTs. So I talked about the prevention piece of coronary CT, but if we're planning all of our structural interventions by CT, why can't we do the same thing for coronary intervention? So, I've got a handful of patients who had a coronary CT, and before they came to the lab, I was able to size and measure the length of stents and kind of plan the procedure up front, which is kind of a foreign concept to coronary interventionalists. But if you look at every other vascular intervention out there, coronary intervention is the only one that doesn't do that. So I think from a preventive standpoint, from a procedures planning standpoint, and really trying to avoid other invasive tests, coronary and cardiac CT is going to be the way we go. What do we do for our patients with renal dysfunction? That's a great question. And whether we're able to offer kind of low contrast evaluations, that's something down the line. But certainly coronary and cardiac CT doesn't replace everything, but there's a role for many and all of our tests. But I think it's going to become the standard of care as we move forward.
Awesome. Frank, this has been super helpful, and the future is obviously super exciting. Any final thoughts before we conclude?
One of the things that is a simple statement, and I've said it, but that I really think drives home the point that coronary CT is different than any other CT, is that coronary CT is a procedure. And this is kind of the phrase I use in our practice. And basically what I'm saying is that it's more of a process than a head CT. And that process includes patient preparation, informing the patient that they're going to need to take some medicines ahead of time. It involves nursing and technologist education. And then it also involves some education on our cardiologist and radiologist part. But really promoting that coronary CT as a procedure, I think, has really, allowed everybody to understand that this is different and that these studies need to be optimized so that we can get all the value out of them that's there.
Fantastic. Thanks again, Frank, for coming on to the podcast. I really appreciate it.
All right, no problem. Thank you, Praveen.
Of course. And to our listeners out there, thank you very much for tuning in. If you like what you hear from us on the podcast, please rate, review, and subscribe to us. Once again, this is the Donut of Destiny. Cheers. Remember to check out the SCCT Starter Kit for a collection of useful resources to help guide healthcare facilities interested in starting a cardiovascular CT program for their patients. It is available for SCCT members free of cost, and it is available for non-SCCT members for a subscription fee of $300 per year.